Good morning, everyone. My name is Dr. György Gulácsi from the Medical Imaging Center of Semmelweis University, and today I'll be sharing my current research projects in the Translational Medicine program. The first research project is the investigation of the effectiveness of advanced MRI techniques in accurately diagnosing cartilage-forming bone tumors. Chondroid bone tumors are quite common. Most of them are benign. Their malignant form, chondrosarcoma, is rare. However, it is the second most common primary malignant bone tumor, following chondrosarcoma. The accurate grading of these cartilaginous tumors is needed because the appropriate therapy differs greatly among the different tumor groups. However, accomplishing this task is not easy, and it needs a multidisciplinary approach which involves radiologists, orthopedic surgeons, and pathologists. Unfortunately, conventional MRI methods are not accurate enough in differentiating the different groups of cartilaginous tumors, and lately relatively new techniques were started to be used to differentiate these tumors more accurately, namely the so-called dynamic contrast enhanced MRI, which assesses the perfusion characteristics of the lesion, and diffusion weighted imaging, which assesses the movement of water molecules inside a tissue. And the third technique, called radiomics, is a post-processing technique which refers to the extraction of mineable high-dimensional data from radiologic images, and the assumption is that these images contain information about a lesion, about a tissue that cannot be seen by the human eye. So our goal was that to compare the diagnostic accuracy of these techniques compared to the conventional MRI sequences with the paired model. So we conducted a diagnostic meta-analysis, and our hypothesis was that these new techniques perform better compared to the conventional ones. And it would implicate a better preoperative clinical radiological decision-making in the treatment of these tumors. We searched in 4 large databases with the search key indicated on this slide. And interestingly, we only found 12 eligible articles after the selection. And unfortunately, only the radiomics had enough articles to have a meta-analysis conducted on it. The other 2 techniques can be only presented by systematic review or a narrative review fashion. So we have the outcome measures in a diagnostic study, the accuracy, sensitivity, specificity, and error under the curve. And the outcomes were the benign versus malignant differentiation, or the benign versus low-grade malignant differentiation, or the low-grade versus high-grade malignant differentiation. We only find for the radiomics enough data for the benign versus malignant differentiation, and unfortunately, we didn't have enough data for the other 2 techniques. So here are the results. We created 4 subgroups. The expert, unfortunately, I cannot show you, so you have the 3rd row, this expert subgroup, which was the radiologist's performance on comparing these tumors. You can see that we have only 1 article with 3 different radiologists on the same patient population had relatively poor accuracy, poor sensitivity and specificity compared to the T1 weighted, T2 weighted, and other subgroups. These subgroups contains radiomics models trained on T1 weighted images or T2 weighted images or other sequences. So we have relatively favorable results, as you can see. But as you can see it on the slides, we have a very wide confidence intervals in all cases. So it should be translated with caution, because we don't have enough data, and these these articles had some methodological issues, and we investigated that too. And as you can see here, only the PAN model had relatively narrow confidence intervals. All the other has very wide confidence intervals, and it was unreliable in these cases. But the preliminary results are favorable, but we cannot draw a conclusion from that, big conclusion from that. So we have a rigorous method selection criteria and article inclusion-exclusion criteria compared to other studies. We added radiomics quality score, which I cannot present you because I have some time limitations, so I cannot go deep into that topic. And we separately pulled these sequences. We didn't just group it together. We separately pulled these T1 weighted, T2 weighted, and other sequences. But we had relatively small sample size, low quality of results reporting, and partially overlapping patient population in these studies. So unfortunately, we cannot make, there wasn't a big difference between, there wasn't a statistically significant difference, unfortunately, because of the insufficient number of articles with uncertain results, and we have in this radiomics articles afloat overall methodology. And we submitted this article just recently. And that's why we planned to do our own study on this topic, and we started to collect patients from the National Bone Tumor Registry, these cartilaginous bone tumors, to see how good it can be in a well-planned radiomics analysis. So basically the clinical question was the same, and the goal was also the same. We had 88 patients with histologically proven chondroid long bone tumors in the registry from 2014 to 2023, but only 42 were found in the PACS system of the university, and unfortunately these were very heterogeneous. As you can see, these sequences are quite heterogeneous, cannot be found in all studies, so we decided to go in another direction. We asked another question because we didn't have enough data to conduct a study on this topic so far. So we asked, can these MRI sequences be pulled together for radiomics analysis? Because a systematic review has just been published in a year before, and they pulled all these sequences together and draw their conclusion from these togetherly pooled sequences. And we saw that it is not a good method, so we investigated, can this be done? So we did a slice-by-slice manual segmentation of these 14 patients, on these 40 patients' images, with 3D slicer software, and conducted an intra-class correlation coefficient analysis on these lesions. So we investigated firstly the role of basic contrast weighing, comparing the T1 and T2 weighted images. And as you can see here, only 3 of those radiomic features that we investigated showed high enough ICC value to be compared directly apart from the other sequences. And the other question was that the role of contrast material, we compared sequences with and without contrast materials with the same contrast weighing, and in this case we found only 9 features that can be put together. So if you pull together all these features, it won't be a good method because it will give you false results at the end. And the AUC values here shows that comparing the T1 and T2 and the T1 and contrast-enhanced T1 sequences, that with radiomics you can extracted from each other with good enough confidence, so they are not similar to each other, so they cannot be pulled together in this regard. So it's an ongoing analysis. We haven't finished it. We added more and more studies, and we plan to finish it this year. So thank you for your attention, and sorry for extending the lecture and the talk. Thank you.
Thank you. Very interesting presentation. Can you please elaborate on the radiomics quality score?
Yes, this radiomics quality score that I mentioned here. So we added to our meta-analysis a radiomics quality score, which investigated the quality of those articles that we used for meta-analysis. It's an accepted checklist with points junctioned to different questions, and you can quantitatively decide how good an article was conducted. And it's the most widely accepted quality score in the field of radiomics. There are others. There are others that just recently been published in 1 or 2 years, but it is the most accepted one. You can render points for the whole methodology then a study went through its publication.
And how is this radiomics quality score in your accepted studies?
Pardon me?
In the articles that you have included?
Yeah. So it was conducted, and they were very poor. So it was, I don't know the exact numbers, but most of the studies that we used were in the group of poor quality of radiomics that was conducted. So they were, I think most of them were poor, and I think only 1 or 2 were moderate.
I appreciate very much your ambition to use the newest method. It's something important, but in the same time you cannot do an appropriate meta-analysis because you have a very small papers in the field that you already shown us. But I wonder if it is not important to compare for the same case these two methods, and in such comparison directly, case by case, perhaps you will have a possible answer. What do you think?
I'm not quite sure that I understand the question here. Sorry.
So it's you cannot use number of papers. Yes. For your you shown us, but you can use for the same case, for instance, in your research, not in this review, to compare the two methods. So not having a big number of patients, having only a direct comparison between the method, between the radiomics and the...
Yes, unfortunately, we only have one study that directly compared the conventional MRI methods, which is radiologist reporting in normal morphological sequences, and we would like to do the same in our diagnostic study, but we have so heterogeneous data because we collect these studies from external hospitals, external clinics, that it is very hard to compare those studies, not because of the quality, but the sequences they either used or not used, because you can only compare one axial T1 to another axial T1. You cannot compare an axial T1 to the T2. That was the second question that we tried to answer on this very low number of patients that we have, unfortunately. And we are collecting more and more patients in order to have statistically significant results in our own study.
Thank you for the presentation. So can you elaborate a bit on what are the conventional MRI methods compared to the new ones? And my second question is about the second study. Like, how is it possible that you cannot recuperate the other articles from the 80 that you have found in this registry? So what are the difficulties?
Okay, so the conventional methods is actually the one that we use in a clinical practice in, for example, Semmelweis University. They are mostly anatomical sequences like T2 weighted, non-contrast enhanced T2 weighted, non-contrast enhanced T1 weighted, and contrast enhanced fat suppressed T1 weighted sequences. We also added diffusion weighted imaging, but I didn't have time to show you. It is not useful for the cartilage forming bone tumors because they have very, very high ADC values. The enchondroma, so the benign one, and also the chondrosarcoma, so it is not a very good method to differentiate between the benign and the malignant chondroid tumors. And we don't use any other things, so we don't use radiomics, we don't use dynamic contrast enhanced MRI. That is the part of the conventional part. And some centers do not use DWI, for example. And why we didn't have 88 patients? Because some patients lost their CD and it cannot be retrieved from the department where they conducted the exam. There were cases where the patients didn't have MRI at all, only an X-ray, and a surgery was performed without a pre-surgical MRI. And there were some corrupted files that cannot be retrieved in our PAC system. So there were technical issues and also some imaging strategy issues that resulted in this very low number of eligible study that we could use for analysis.
And György, as an expert specialist who was working with these tumor images, you've seen a lot of cases and images. So I'm curious, what do you think, does your brain better than those experts in that study? Would you say that you have now a better performance talking about sensitivity or specificity than a usual radiologist? So the data is there in the pictures, or is just inaccessible to human eyes?
Yes, the data is there, but there is no direct comparison in one article with the conventional methods and the new one, for example, radiomics. So we excluded those studies that were only conducted about the diagnostic accuracy of the conventional methods. We have plenty of that, and it is just as I indicated here. We have an accuracy of 60 to 80%, which is not very, very high, unfortunately. But in that PAN model, it was even lower.
It was around 50.
Yeah, it was absolutely unacceptable, like a 40 to 60.
But you now, as a researcher on the topic and a radiologist, do you think that for yourself, as you saw, because they are very rare images for normal radiologists, but you worked with it, so your brain is better processing these images now, or there is a limitation?
There is a limitation, but I think, I don't want to look like a big-headed specialist, but I think this sensitivity would be higher in a tertiary sarcoma center trained radiologist compared to these three radiologists that was performed poorly in this case. Unfortunately, we don't have, we only have this direct comparison. And that's why, that was one of the reasons why we decided to conduct our own research to see how we compare to the radiomics and to the other radiologists who went through this comparison with the radiomics. So.
Okay, and we means that a team who was working with these images for a longer period.
Yes.
Okay, thank you.
Thank you for the presentation. I have questions regarding basically the reference group in your case. So can we go to a slide with the weird framework on it? So you here you say that the conventional MRI is your reference group.
Yes.
So and the conventional MRI is basically the method.
The experts.
The method they use
yes.
currently. And in an earlier slide, you said that the conventional MRI has a specificity and sensitivity of 70%.
So 60 to 80.
So my question, can you really use this conventional MRI as a gold standard? Because this has 60, 70, 80% specificity, and you compare a new method to a not perfect method. Yes. In theory, there could be a case that the new method is simply better, but you compare it to a bad method, and you have lower specificity because maybe you correctly specify a positive with the new method, but that you incorrectly classified with the conventional method. So my question is, can you really use this conventional MRI as a reference group, or is there a better reference group?
We don't have a better imaging reference than conventional MRI, which is clinically spread. You know, that is the method for local staging, the gold standard method for local staging. You don't have better options that is in the clinical use.
And
right now.
How was the specificity of the conventional MRI calculated? So what was the reference?
I know your question. So all these patients were either the tumor removed and went to histology, or a biopsy. Biopsy followed the MRI, but unfortunately, even the biopsy has false positive and false negative rates because of sampling errors. And even the surgical removal, and after the surgical removal and the sample analysis can give you some questionable results because the difference between a low-grade malignant tumor and a benign tumor is very small, even on the histology slides. So that's why it's a very, very, very hot topic to pre-operatively conduct a better tests than we have right now. So we compare the conventional MRI to histology to calculate the specificity and sensitivity, but even histology has some issues regarding its diagnostic accuracy, unfortunately, in those cases where there is only a little difference between a benign and a very low-grade malignant tumor.
Thank you. And my other just a comment, and it's a re-emerging thing that I've noticed, that in diagnostic methods, usually the hypothesis is like the new stuff performs better compared to the gold standard. And my comment is that you cannot say that.
It was a clinical. So the hypothesis is that it is the same, so there is no difference. But because of the preliminary results, we hypothesized that they would perform better. But yes, as a researcher, you should use the word it didn't differ, or there is no difference between the tests. Yeah, I accept that.
Thank you.
Congratulations on your presentation. My question would be: are there any other advanced MRI techniques that we could use for similar purposes that you haven't mentioned?
Very good question. I need to think about maybe MR spectroscopy. I don't know about it if it is good for cartilage-forming bone tumors, but theoretically, it can be another advanced MRI technique. Right now, in today's world of MRI, there are no new sequences. Right now, the situation is that the emerging new techniques try to accelerate the MRI scan time. There are no new sequences that I know of, so I can only say that maybe MR spectroscopy has some role, may have some role, but I'm not so sure about that because we haven't found any articles on it. But theoretically, maybe that's a tool that can be used.
So you started this research and you found that there are very few data on the field. And you very nicely concluded that you would do your own research. And you also found that you have quite a few patients, and that was really even reduced down because lack of,
yes.
you know. So the question is whether you did some sort of power calculation, that whether your patients you have in hand is enough to solve the issue, or why didn't you opt for a more, you know, multi-center study or international study or whatever, because data is seemingly are very few.
Yes, we approached 2 foreign centers, but unfortunately they do not do this kind of research because of these issues that this is a condition that has very low incidence, so we have few patients in the country, unfortunately, and when these patients scanned, sometimes it's an incidentaloma. So it is not a tumor-specific sequences that are used, and the surgeons can operate on those non-special sequences because it contains most of the information that is needed for local staging, but for research purposes and to make a new model and to train a radiomics model, it would need other sequences, and that's why they told us that okay, the data is so the imaging sequences are heterogeneous. It is very hard to collect enough patients, so they have the same issues. Large centers like Heidelberg, for example, that we approached. And the other question is, because radiomics is data-driven, it may not be needed to calculate it in advance. Sometimes you need even more than it is calculated, and when an approach is data-driven, as far as I know, it shouldn't have this pre-calculations because it can change in the sequence of the research.